day, everybody. My name is Matti Tolonen. I'm a consultant emergency surgeon from Helsinki University Hospital, Finland. And we will have to record a talk I gave in the Danish Surgical Society meeting in November 2025. And the talk will be about surgical strategies in severe acute pancreatitis. And I'm grateful for the BJS Academy to give me the chance to give the BJS talk. Got nothing to disclose. So just briefly about our hospital. We're quite a large hospital, the biggest in Finland, and according to the way of calculation, one of the biggest in Europe. We have 2,600 beds and 25,000 employees here in our hospital or in our hospital network. In our campus in Meilahti, Helsinki, there's more than 100,000 emergency room visits annually, and we perform more than 10,000 emergency surgeries a year. There are 38 ORs, of which 4 are hybrid ORs, and 1 Raptor suite for trauma. And our tertiary cases catchment population is about 1.7 million, and we do get all the severe pancreatitis patients who need interventions into our hospital. And I work in the emergency abdominal surgery ward where we have 60 beds. So about the talk, I'm not going to try and tell you that we're doing it the best way. I'm just sharing our experience, and it's not a literature review. Obviously, it's science-based, and there's some literature, but we're not going to go through all of them. I will try and to be very pragmatic and reflect our institutional practices and the way we think about how this disease should be managed. This is a surgeon's perspective, and I have integrated a real-life patient case in the talk to make the points more clear. So first of all, pancreatitis is very different from most emergency general surgery diagnoses. And why is it so? So with pancreatitis, we are dealing with inflammation instead of most other diagnoses, which are usually infections, bleeders, obstructions, or ischemia. And because of the inflammation, it's wiser to do as little as possible, because the patients don't tolerate surgery very well, especially in the early phases of the disease. So all the interventions only when we must, and preferably as late as possible after 1 month of the onset of the disease. These patients may be ridiculously ill, and nerves of steel are needed not to do too much at the early stages. And centralizing these patients and having the severe acute pancreatitis patients in only a few centers will help, because then we gain experience. And it's not just about the surgeons, it's also about the intensivists and all staff members. Severe acute pancreatitis is not a common disease, and we need to manage physiology first. And in my opinion, it has pretty much nothing to do with elective pancreatic surgery, and it should be managed, or optimally is managed, by emergency surgeons. So how do we define severe? The most typical classification contains mild, moderate, or severe disease, and with severe disease, it means that there's organ failures that persist for more than 48 hours. About the types of pancreatitis, edematous pancreatitis is usually less severe, and the severe ones tend to be the necrotizing ones. And about terminology, in images A and C, we see edematous pancreatitis, which may or may not develop into a pseudocyst, and we are not allowed to call it a pseudocyst until 4 weeks of the onset of the disease. And on the B and D images, we see necrotizing pancreatitis, which we call acute necrotic collection before 4 weeks, and after 4 weeks it may be called walled-off necrotic collection, which in this case is infected and is visible by the gas bubbles in the collection. So in our hospital, we manage about 460 pancreatitis patients every year, and we get the severe cases from other hospitals as well. But still, even though we cover a reasonably large population, we only get 40 to 50 patients every year. Although these patients tend to spend a lot of time in the ICU and in the wards, so we have these patients all the time in the hospital. Of the severe cases, only 1 in 4 needs a necrosectomy, which equals to 10 to 15 patients every year. The median age of the severe cases is a bit less than 50 years of age, and the median hospital stay is almost 1 month. In Finland, the etiology is mostly alcohol, where in most countries the biliary etiology is more common. Overall mortality in our hospital is 18%, and the mortality increases heavily with age, and with patients less than 60 years old, the mortality is around 10%. And we do know that it's lower when the necrosectomy can be postponed for more than 4 weeks. So let's bring our case in with when the background of the slide is blue, then we're talking about the case. So we have a 50-year-old female patient with some mild basic diseases and occasional alcohol abuse, a bit obese. Abdomen has not been operated before. So she had been drinking for 5 days, vomited repeatedly, and had abdominal pain 1 day before calling the ambulance. In the emergency room, she was slightly anxious, having trouble breathing, tachycardic, blood pressure still normal. The abdomen was severely painful, distended, and the palpation was described as peritonistic. The ABGs showed that she was severely ill with very low pH and elevated lactate, as well as elevated hemoglobin. So we see here that the CRP after 24 hours of disease was 112, and the white blood cell count, hemoglobin, creatinine were all elevated, and mild elevation in the liver enzymes, and also the amylase was elevated. So we decided to do initial CT for this patient without contrast. We'll talk about it more later, so we could be absolutely sure that the diagnosis is right and we're not going to miss a perforation, for example, and we see a severe pancreatitis. So about the diagnosis, usually we are good with 2 out of 3, typical pain, elevated lipase or amylase more than 3 times the upper limit, and characteristic imaging findings. Having said that, for all the patients who go to the ICU in our system, we do a CT. Mostly when we want to just be absolutely sure of the diagnosis, we do it without contrast, even though the risk of contrast-induced nephropathy is questionable. But sometimes we see patients coming from other hospitals who have elevated amylase, and they still have a perforation or mesenteric ischemia or massive gastric dilatation. And something should be done to these diseases, not just intensive care management. Also, in the early stages, we try and figure out what is the etiology of the disease. The ultrasound needs to be done within the first day if there are gallstones or common bile duct dilatation. We also screen triglycerides and calcium, which are very rare, especially the calcium is a very rare cause for pancreatitis. Sometimes we see hypertriglyceridemia induced pancreatitis. We ask about alcohol usage, sometimes use some labs to elaborate what the patient is saying, and we ask about new medications, and sometimes the reason may be obvious, post-ERC or post-operative or post-traumatic. So how do we diagnose the severe form early? Obviously, as per the definition, we look for acute organ dysfunctions. There's the BICEP score, which seems to perform reasonably well. We don't use it in clinical practice because I think it's fairly simple for the acute organ dysfunctions. Also, if the patient has very severe pain or elevated hemoglobin, as our example patient here has, the hemoglobin elevates not because of dehydration, but because of vascular leak, the effect called third spacing. A patient was admitted to the ICU, intubated. We started prophylactic low molecular weight heparin and started to manage the multiple organ failure. And this patient had 4 organ systems that had failed. On the second day of the intensive care, the CRP had elevated quite high. The patient had a progressive acute kidney injury, and intraabdominal pressure was between 22 and 26 in several consecutive measurements. There was an interesting systematic review and meta-analysis in World Journal of Emergency Surgery 2024, which quite nicely shows that in the severe form of pancreatitis, the patients do benefit in various outcomes of early initiation of low molecular weight heparin. It's not sure why, but most likely because it might affect the microthrombosis associated with necrotic disease. So in general, should we use antibiotics on these ridiculously ill patients? The answer would be in general no, but there's always a but. If the patient has acute organ dysfunctions and we take the patient to the ICU, there's a good chance that there might be early bacteremia, and we do know that that's starting antibiotics too late in sepsis will affect the outcome. Also, occasionally there might be cholangitis. So what we do, which is not evidence-based, but we feel that there's a rationale behind it. We start 3 days of cefuroxime just to cover the most common bacteria, E. coli. But if the blood cultures come out negative and we can't prove any infection during those 3 days, we discontinue the antibiotics regardless of how sick they are. And the goal here is that not to dwell these patients with a broad spectrum antibiotics. So when the patient eventually might get the infected collection, the goal is not to have any bad bacteria in it, but the most common non-resistant bacteria. Here's a study from British Journal of Surgery 2009, which shows that in all pancreatitis, about 1 out of 4 will have an infection, and the reason for the infection in a bit more than half of the cases is the infected necrosis. So we see that in the first week, the infections are mostly outside the pancreas, not the necrotic pancreatitis. And when time goes on, the proportion of pancreatitis or the infected necrosis will grow. So what are the indications for surgical interventions in severe acute pancreatitis? In the early stages, if the patient hasn't fully established abdominal compartment syndrome, we need to go into the OR and do a laparostomy because there's a very high risk for intestinal ischemia and other problems if left untreated. Also, if we have a perforation in the GI tract which is not contained, we might need to do a laparotomy. This usually happens later in the course of the disease. In the early stages, there also might be bowel ischemia, bowel necrosis, or necrotizing cholecystitis found in the abdomen. Bleeders are usually managed endovascularly, but if that is not possible or available, then surgery might come into hand. This is also a late manifestation. And as a continuum for step-up approach, preferably after 4 weeks of the onset of the symptoms, surgery might come in at place. Another study from Annals of Surgery shows that there's 900 patients with acute necrotizing pancreatitis, and it's quite a high number. That 16% of these patients actually do develop a perforation in the GI tract at some point. These perforations usually happen, most often happen in the duodenum or colon. So if there is bowel perforation or a fistula in the upper GI, if it's contained and drains into the necrotic collection, or I think it's more precise to say that the necrotic collection drains in the GI tract, it's usually just wise to drain it inside the GI tract and let the collection dry there. Colonic perforations are usually more late presentation. The inflammation and the collections might eat a hole in the colon, and sometimes we feel that we have more of these patients since we've been more conservative towards the collections. It might be difficult to diagnose, especially when there's an infected collection with some air bubbles. It might be hard to tell if there is a hole in the colon. Also, we might do colonoscopy or fistulography or see something in the CT scan, but it's not always easy. And if we need to operate these patients during acute inflammation phase, we generally avoid anastomosis with very bad experiences on those. When they dwell in the region of the pancreatic fistula, they do not do well. And occasionally we also see some fistulas from the dried off collection into the colon, and if the patients are very completely asymptomatic and at home, these do not need any management, but it's a rare thing to happen. So back to our case, all the maximal conservative methods to lower the intraabdominal pressure were done, and still the pressure was between 25 and 29 millimeters of mercury. The kidney injury got worse, lactate rose again, vasoactive requirements got worse, ventilation got worse, and our intensivist was not happy at all. So what we have now is an abdominal compartment syndrome. It still happens. It's much more rare than some years ago, or at least 10 years ago, because I think our intensivists have gotten better with fluid resuscitation and using smaller amounts of fluids, and therefore it has almost disappeared, but we still have it sometimes. This is the patient we opened up. There's already some hematomas or ischemic changes in the small bowel, but no necrosis, no perforations. And while doing the laparostomy in the early days, we might see some necrotic collections. Sometimes they might crawl on top of the colon, and the colon might look even necrotic, but usually it's not the problem at that time. It can be, but it's rare. And these necrotic collections should not be touched in the early stages at all. So just leave the abdomen open. And when we do leave the abdomen open, how should we manage it? I think there's quite a reasonable consensus at the moment that the vacuum-assisted wound closure and mesh-mediated fascial traction is recommended by all the guidelines, and it gives us really good results in terms of not many fistulas in the abdomen, and secondary closure rates should be close to 100%. There are some other options or adjunct options. If we suspect that there will be difficulties to close this abdomen, botulinum toxin should be used early on to facilitate the closure. Direct peritoneal resuscitation is an interesting thing. There's not enough good data to really support its use yet, but and it should be more studied, but it sure is interesting. Also, some new devices that can provide vertical traction might come in helpful, but also lacking good data still. Nowadays, more rarely, if we cease to close the abdomen with the mesh-mediated fascial traction and it stops progressing, we might sometimes do a minimally invasive subcutaneous component separation, which will give us 4 to 5 centimeters on each side and facilitate the closure. This was just a very small study from Sweden, 2019, from the same group that invented the mesh-mediated fascial traction, using a permanent onlay mesh sutured in 2 rows, 3 centimeters apart. And this is used if the fascia is bad and it doesn't tolerate the pull from the mesh. You can suture it like this, and it really sticks nicely even into very poor fascia. And you can leave the mesh and just close the mesh at the end of the management, and it works really nicely. We also use this for fascial ruptures or re-ruptures, and the initial experience with about 100 patients has been really good. And sometimes it can get really, really hard. I think this is, I know that this is the last patient we were not able to close. The delayed primary fascial closure was not achieved, but we had to use skin transplants, and the patient did not end up well, ended up dying on multiple complications. But it's extremely rare to see patients like this anymore. So our case patient went through 3 dressing changes, mesh tightenings, and delayed primary fascial closure, which was achieved in a reasonable time. The renal replacement therapy was continued, and the patient was in a plateau phase, CRP in about 300, and the organ failure score fluctuated between 11 and 16, and no antibiotics were given. However, on day 19, there were several changes to worse, which led us to taking a CT scan. We don't routinely CT scan our patients based on any certain day, but we do the CT scans when the patient gets worse, or if the patient gets worse. So here we see widespread collections, mostly in the upper abdomen, and not so much paracolic. So when does the necrotic collections get an infection? Usually, this is from our hospital. I think it was around 170 patients. The first infections came after the first week, and the median time to get the infection was about 4 weeks, and almost all of the infections had developed in 2 months' time. This is an interesting, well-performed Dutch randomized control trial of patients with infected necrotizing pancreatitis, and they compared immediate drainage versus drainage after 4 weeks. And there were no differences in complications and mortality, but the delayed group ended up having less drains and less necrosectomies, which was really interesting. So what are the indications for percutaneous or endoscopic drainage of these collections before 4 weeks has passed? So if the patient gets worse with signs or strong suspicion of infected necrotizing pancreatitis, we need to keep in mind that the CT will only show you air bubbles in half of the cases that are infected, and the fine needle aspirations, which we don't perform anymore, have a good chance for false negative findings. And occasionally, the percutaneous drainage is sufficient as monotherapy. It happens in more than a third of the cases. And also, if the collections are small and central and the patient is doing well, antibiotics only might be an option, and we don't always need to drain the infected collections. So back to our patient. So we suspected that the reason for the worsening on day 19 was infected necrotic collection. We did a ultrasound guided percutaneous drain, which was inserted dorsally, as we like to do it, because they might stay in for a while, and we want to have the channel developing as dorsally as possible. So the amylase was high, indicating a pancreatic fistula, and there was E. coli growing as bacteria. We started off with meropenem and changed it to cefuroxime after we got the cultures. So the patient started to get better, was extubated, got back her diuresis, and after 1 month in the hospital was transferred to the surgical ward. The drain was still in place, produced about 400 mils a day, and showing pancreatic fistula. So what are the indications for late interventions? We might use any possible method as a continuum of a step-up approach when it's needed. And ongoing organ failure without signs of infected necrosis is also considered an indication for intervention. Also, gastric outlet, biliary or intestinal obstruction due to a large collection disconnected duct syndrome, or symptomatic or growing pseudocysts. And later on, after 8 weeks after the onset of the symptoms, also ongoing pain and discomfort may be considered as an indication. However, the 4 weeks time limit, it's artificial, and all the patients might not follow it. Here are examples from a study showing that there's 46 days passed and still the collection is not well demarcated, not well walled off, and not ready for intervention. And another example at 25 days, which is already nicely capsulated and ready for interventions. So we have to individualize our decisions. So the options for late interventions when drainage and antibiotics are not enough and the patient does not get better. First of all, we need to consider where is the collection. Is it central only, unilateral, or bilateral? This will affect our approach. The central collections should be mostly approached by a transluminal approach, either endoscopic, minimally invasive, or surgical approach, transgastric approach. Occasionally, the approach may be also transduodenal, or some have even reported transjejunal approaches. However, the collection needs to be in contact with the lumen of the GI tract that we're going to use. And if we have a disconnected duct, pancreatic fistula, and we use a transluminal approach, we will create the fistula into the GI tract, which will make it asymptomatic eventually. The open surgical option allows also cholecystectomy, but if we use endoscopic approach, we might perform laparoscopic cholecystectomy a little later. The endoscopic approaches usually need multiple procedures. So in the first stage, there might be also only a lumen-opposing metallic stent put in. You can't do much more, and you have to go back for endoscopic necrosectomy several times. And sometimes endoscopic transpapillary drainage with ERP is also an option, depending on the anatomy. So with very widespread collections, the classic open necrosectomy is still an option, and some centers like to use the VARD, the video-assisted retroperitoneal debridement, as their approach. The problem with these approaches is that they both have a very high risk for external pancreatic fistula because we create channels outside the body. The good thing with the VARD approach is that it's more minimally invasive, and the bad thing is that you usually need multiple procedures and longer drainage for this. The classic open necrosectomy, there's a good chance to create some iatrogenic lesions, and the patient will get sick because there's a lot of mobilization and might get new acute organ dysfunctions after the procedure. The good part is that it's usually a single state procedure, and you can perform a cholecystectomy while doing it. So how to choose the individualized intervention for each patient? There's good evidence that the step-up approach is recommended because there's a good percentage of patients that do not require further interventions after the initial drainage or antibiotics, and sometimes antibiotics only in small central collections. We need to consider what we can do in our hospital. Some have performed these procedures with robotics or laparoscopy. But the etiology of the disease, do we need to remove the gallbladder? Is there a disconnected duct, a pancreatic fistula associated with it? We need to look at the anatomical dimensions of the collection. How much solid necrotic content is there and how much liquefied content? It's not always easy to say from the CT scan, but you can make a good guess. The good part with minimally invasive strategies is that they cause less worsening of the organ dysfunctions, but usually do require more interventions and perhaps a longer time in the hospital. Some papers say that there's higher mortality in the open surgical options, but actually when you look at all the papers, there's absolutely no evidence to show differences in mortality in these late interventions that are done more than 4 weeks after the onset of the disease. And we need to also consider that how fragile is our patient, and does our patient better tolerate the prolonged inflammation or infection, or a single acute physiological insult and faster recovery after that. What we do is that we have a multidisciplinary meeting for the decision, and also include our patient and give the patient our options, and some don't mind the open surgical wounds, and some really don't want that. So this is how the decisions are made in our hospital, very much individualized. Back to our patient, still at the ward, drain at place, and now we see quite localized collection in the upper abdomen with the disconnected duct syndrome. So there's an option called the open transgastric necrosectomy, or surgical transgastric necrosectomy. It was first published 2016, and a large study from North America was published a couple of years later. And after the second study, 2018, we also started doing it. So basically the technique is that you make a transverse incision in the upper abdomen big enough to fit your hand through it, and then you go through the anterior wall of the stomach, and you find the bulging collection from through the back wall of the stomach. Put a needle in, take some samples, leave the needle, and use it to guide yourself to the collection. You open up the back wall of the stomach, and you end up in the necrotic collection. And then you do the necrosectomy, being gentle, not yanking any tubes, and getting as much as the necrotic collection out as possible. At the end of the procedure, we suture the front wall of the walled-off necrotic collection into the back wall of the stomach, just to make sure that the contents do not go anywhere else than into the stomach. So we suture it round and round. It's also good to lessen the chance of bleeding. We put a tube in from the nose, use it as a nasocystic drain to drain the collection. Then you close the anterior wall of the stomach, the abdominal wall, and you're all done. So this is what we performed to our patient, the surgical transgastric necrosectomy on day 38 after the onset of the disease. And due to an elevation of inflammatory parameters, the patient had a complementary endoscopic transgastric necrosectomy, where the image is from 1 week later. Was discharged a few days later, had some antibiotics still at home, and then came to the outpatient visit 6 weeks later, and there we see that the collections have dried out, and we see a contact between the disconnected duct and the stomach, which is the goal. When we started doing this, it was really difficult for the radiologist how to put their words to see that there's kind of a fistula or a hole at the back wall of the stomach, because they didn't realize that what we had done, even though we tried to tell them. But nowadays they're okay with it. So with the recovery, we need to expect some complications and keep our patients in outpatient visits until clinical recovery. We often do the CT scan and take the labs and see how the collections are. With small collections that are asymptomatic, we're not that worried, but with symptomatic patients and growing collections, we might need to do something later on. And we should treat the patient, not only the CT scan, and also look for venous thrombosis in the upper abdomen, which might need some management. We need to actively seek for endocrine and exocrine dysfunction, so that the patients won't have untreated diabetes or problems with digestion. And also we need to advise our patients to quit alcohol use and smoking. This is a study from our hospital from last year, and we studied the pancreatic exocrine insufficiency, having the controls in 1 to 2 months and after 1 year. And of these moderately severe or severe acute pancreatitis, 1 out of 3 developed the exocrine insufficiency, especially when the necrosis affected the body of the pancreas and the patient had a new onset diabetes during the hospitalization. And some of the patients with no initial pay developed it in 1 year, and also the other way around, that some who had it at first place did not have it later on. So we need to keep these patients in control. Here are just some other examples of interventions. Here we had a patient with the infected collection very high up in the mediastinum, who had a hot axial stent from the proximal stomach into the collection, and another patient with central collections ended up having a open transgastric surgery. And here we can see, just with doing a bit of work with your finger in the collection, most of the pancreas came out. This is a third example of a very widespread collections on both sides, and we decided to do the classic open necrosectomy. The patient did well. So my take to work message here is that centralize this rare disease, since it needs experience, and there are not so many patients that need interventions. At the early stages, be absolutely sure of the diagnosis, and early surgery is performed only for extrapancreatic reasons. And the good idea is that less is more and late is better, and let the physiology drive the management, not the CT scans. Step-up approach is advisable, and we need to individualize late interventions. Consider your patients, consider the expertise in your hospital, and have a multidisciplinary meeting. And just as a reminder that there's no difference in mortality in terms of the intervention methods. Thank you very much. I thank you for your attention, and we'll finish off with some literature used in the presentation. Thank you.